Time for another DAROGA lecture, part 1 of pelvic organ prolapse. Here an overview of when I was preparing this lecture of the sunset here in Adelaide, and also a few more pictures with a few minutes interval, just to distract you a little bit from this quite complicated topic. Part 1. I would like to start with a brief overview of the anatomy and the support systems of the uterus and the vagina. We discussed the epidemiology. What is the prevalence of prolapse? What are risk factors for pelvic organ prolapse? And important part of part 1 is what is required for the diagnosis? What symptoms do women present with? What questions should we ask for? At examination, how do we classify prolapse and how do we determine the severity of prolapse? It can be done in 2 ways: subjective by the woman herself, that's the most important part of course, and then a grading system used by doctors, and then a number of conclusions. Part 2 will focus on management options, as you can see here what options are available, which one should we prefer, and we finish as always with conclusions. The topic pelvic organ prolapse is also known as uterovaginal prolapse. The anatomy, support of the uterus and the vagina. Both uterosacral ligaments support the cervix and prevent especially descent of the uterus, and moreover we have pelvic floor or the Levator Ani muscles. I will show you a few pictures to explain this. Note that the round ligaments, the ovarian ligaments or the infundibulopelvic ligaments do hardly play a role in the support of uterus, cervix and vagina. A brief refresher. Here we see a picture from at laparotomy. The anterior abdominal has been removed. Here we see successively the round ligament, the ovarian ligament, the uterosacral ligament, and the infundibulopelvic ligament or the suspensory ovary ligament. The broad ligament and the parametrium, they don't play an important role in support of the uterus and the vagina at all. If you want to have another look at the anatomy, I would like you to refer you to the YouTube video about female and male sterilization, and you can see here the direct link. The pelvic floor muscles or the Levator Ani muscles, viewed from below. Anteriorly we see the cross-section of the urethra, the cross-section of the vagina, and the cross-section of the rectum. So these 3 channels actually pass through the pelvic floor muscles. And we see here the so-called pubococcygeus muscle, which runs like a sling around the 3 openings we just discussed. The second part of the Levator Ani pelvic floor muscles is the so-called iliococcygeus muscle, which runs more posteriorly, but also has partly a sling type structure. So when a woman would tension these muscles, it's clear that it compresses the rectum, the vagina and urethra, and by that nature it will be able to control bowel and bladder function and plays a role in incontinence as well. If we take a lateral view from the same pelvic floor muscles, we can see here part of the bony pelvis is removed. We have a lateral view, and we can see here the iliococcygeus muscle, and here in front the pubococcygeus muscle. And again we see here the urethra, the vagina and the rectum, which run through the opening of these pelvic floor muscles. During labor and delivery, well, if the head is about to crown, we can see that the vaginal wall is stretched to the maximum and can tear. The same with the pubocervical fascia here at this part. We can see as well sometimes that compression of the pudendal canal and the pudendal nerve can take place, which can result in temporary damage. But also we see the maximum stretching of the levator ani muscle. And it's probably no surprise that after this major event that women who delivered babies vaginally, and particularly big babies, are at risk for pelvic organ prolapse or uterovaginal prolapse later in life. So far, a brief overview of the relevant anatomy. The epidemiology. How often does prolapse occur? This is not an easy to answer question. Reliable data are scarce, and what do you define? Women who have an anatomical variation, women who have typical prolapse symptoms, what age, etc. So the prevalence hovers between 24 and almost 50% of women, according to some of the studies I quoted here. When you look at the data from the very big Women's Health Initiative study, which was published in 2002, by the way, that was a big study in the general population where women were given HRT to find out whether that would have a cardioprotective effect. But in that study, women were also asked for prolapse symptoms and they were examined. And you can see here that 41% of the women between the age of 50 and 79 years of age had a symptomatic prolapse. The majority of those women had a cystocele, a smaller percentage had a rectocele, and even a smaller percentage had uterine descent. The natural history of pelvic organ prolapse. Most of us would think intuitively that it will tend to worsen over time. And this study, rather, it's maybe a smaller study, but still interesting to look at. A prospective cohort study published in 2010, where they looked at 160 women with prolapse symptoms with a mean age of 56 years and 120 controls, women who are completely asymptomatic with a mean age of 51. They were given a questionnaire, extensive pelvic organ prolapse questionnaire at the beginning of the study, and they were also examined and they were classified according to the POPQ classification, which I explain a little bit later. And that was done at the start of the study and after 5 years. And interesting were the findings after 5 years of the women who were initially symptomatic, who had typically a feeling of vaginal bulge. 30% of those women were the same. 64% showed some improvement, and 6% worsened over time in the 5 years' time. If women were asymptomatic at the start of the study, 2% developed prolapse symptoms in 5 years' time. So those figures are not too bad. POPQ, when you look at the examination findings, 47% of women had no worsening of the prolapse, 40% had a slight improvement of the anatomical variations, changes, and 13% showed worsening. So interesting here from this study, was it not a big study, it shows that prolapse does not necessarily have to worsen over time, which can help us if we inform women about treatment options. What are risk factors for pelvic organ prolapse? Advancing age, menopause, Caucasian race, parity, as we have seen before, pregnancy and in particular vaginal delivery of a large infant. The little m indicates modifiable, at least if you would realize that large infants occur, or LGA babies occur more common in women with gestational diabetes. That's something that could be influenced. A lower segment cesarean section is not absolutely protective, so in fact pregnancy itself has an impact on pelvic organ prolapse tendency. Important to take on board that previous surgery for prolapse or for hysterectomy, and hysterectomy for instance for menorrhagia, they will remove part of the existing or affect part of the existing support system. Hence, surgery is a risk factor. Other risk factors, a very rare one, is joint hypermobility. So that has to do with the laxity of collagen, as depicted here. Lifestyle, high impact activities in particular, and important, some chronic conditions such as chronic lung disease, chronic cough, constipation, which result in chronic strain when opening bowels, and that has a negative effect on the pelvic floor anatomy. Obesity can be addressed, and smoking. All are risk factors for pelvic organ prolapse. Recurrence rates after a procedure, the recurrence rates, a very precise figure is hard to give, but it's between the 10 and 30% in general. And important to tell women when we do the informed consent for a procedure. So there is no guarantee that it will fix the prolapse forever. Important now the clinical presentation. What are typical prolapse symptoms? A heavy dragging feeling from below, lower back pain, a bulge or lump felt in the vagina or vulva, particularly when standing, or worsening during the day. There are typical bladder problems coinciding with prolapse. Straining, incomplete emptying, urinary retention, or recurrent UTI can in particular point at a anterior vaginal wall prolapse. What typical bowel symptoms? Constipation, unable to empty the bowel. The woman needs to help with her fingers. That's called digitation or splinting. That's required to evacuate stool. And these symptoms typically point at a rectocoele. Sexual function. Usually no dyspareunia because the prolapse tissue is soft. And of course important that there will be shame and avoidance. It's important that all four aspects of prolapse symptoms are part of a thorough and detailed history. A recent study published in The Lancet, the PUPPY study, showed also the symptoms in a slightly different way, but something is coming down. That was the most prevalent symptom. Discomfort when standing, abdominal pain when standing, lower back heaviness, strain to empty bladder, the feeling that the bladder is not empty after going to the toilet, and the same applies for bowel, feeling is not empty. So these are typical prolapse symptoms focusing on the bladder and the bowel and the sexual function as well. What might a woman think if she has a lump down there? What might she be afraid of? Well, most commonly what I've experienced is that women are embarrassed. They keep it to themselves. They don't share it even with their intimate partner. Lump could be associated with the fear of having cancers, but here important that we as doctors should not second guess. Don't assume anything. Ask for this explicitly when you take a history. What is going through your mind, and you will find out. And you can address her thoughts or fears explicitly. Okay, let's move on to examination and classification. There are four possible parts of the pelvic organs which can be prolapsed. Firstly, the cystocoele. Secondly, a rectocoele. Thirdly, an enterocoele. And last but not least, a uterine descent, or a combination of one of the first four. How should we examine a woman presenting with pelvic organ prolapse symptoms? I would recommend for most doctors to do it when the woman is in dorsal lithotomy position. We are familiar, most of us are familiar with this bivalve speculum, which we use for cervical screening, to take a pap smear, to take swabs. And the only difference is that we should turn the bivalve speculum, as depicted here, gently 90 degrees. So you turn it 90 degrees in the 3 to 9 o'clock position, so the blades are sideways, which means you are able to observe the anterior and posterior vaginal walls freely without interference of the speculum. Most doctors are familiar with this way of examination, so that would be my recommendation. And of course we have to realize that some specialists, urogynecologists, they might prefer to examine a woman in a standing or a left lateral position, and they might prefer to use a single blade vaginal wall retractor as is depicted here. What are the findings when we examine a lady with prolapse? First part is inspection. Look at rest and find out whether you can see something appearing beyond the hymenal ring. Then you ask her to cough or to bear down, the so-called Valsalva maneuver, and you look once more and you try to find out, do I see a bulge, a lump appearing in the introitus, in the hymenal ring area or not? For a cystocele, it's clear that the anterior vaginal wall is coming down and bulging. How far does it come down when she's bearing down? Typically, for an anterior vaginal wall prolapse, the vaginal rugae, the little folds, have disappeared. The vaginal wall, as it were, is stretched out. Same applies, bulging of the posterior vaginal wall, when that's visible, that's consistent with a rectocele. No more vaginal rugae are visible, and you ask yourself as well, how far does the posterior vaginal wall come down when she is coughing? Sometimes we can see that the cervix is visible low in the vagina or even in the introitus or protruding beyond the hymen, which is consistent with uterine prolapse. After thorough and systematic inspection, we will do a combined rectovaginal digital examination, and mainly to confirm what you have seen already. In particular, sometimes we can feel the enterocele appearing in the posterior vaginal wall between the rectum and the vagina. The bowel, the small bowel, might be palpable, pointing at an enterocele. Of course, it's important that a woman feels exposed and is in a very vulnerable position. She feels very embarrassed. So always ask permission for examination. When you examine and you're waiting for a supervisor, make sure that she is not in the lithotomy position. Make sure that you always use a chaperone to support her. Be gentle. Stop the examination if at any point in time it's painful, and explain verbally always what you're doing. I'm inserting the speculum, I'm turning the speculum around, and in between maintain eye contact and reassure her as much as possible. In my experience, that gives you the most reliable findings at examination, and also it makes it quite tolerable, acceptable for the woman involved. Explain your examination findings after you've examined her and she is dressed again. Okay, this is a diagram what we could see in case of a cystocele or an anterior vaginal wall prolapse. From the 12 o'clock position, dorsal lithotomy, we can see a bulge appearing, which is of course not very clear in a standstill picture. In a cross section, this is what it is. You can see that the anterior vaginal wall, this is the anterior vaginal wall, and part of the bladder are prolapsing and are even here probably visible at the level of the introitus. So this would be an isolated cystocele because the rectum here does not appear to be bulging, and there is a slight descent of the uterus here, but the main component is the cystocele as depicted here. Then the rectocele. At inspection we see now a lump appearing from 6 o'clock, from behind, from posterior, but in a standstill picture it looks quite similar to a cystocele, so only the dynamics when examining a lady can tell you whether you're dealing with a cystocele coming from 12 o'clock or a rectocele mainly coming from 6 o'clock. Here we see the cross-section where the rectum and the posterior vaginal wall legs are stretched and they appear at the level of the introitus. There is no obvious cystocele here and the uterus is in a normal position apparently. Then, so this is the hymen or the hymenal ring. These remnants are important because they are a reference point as to where we can refer the prolapse to, because the hymen does not prolapse. And it's a good reference point, a reliable reference point. Rectocele, as discussed. Enterocele, here we see a diagram where there is a small bowel hernia here in this recto-vaginal space. Rectum here, vagina there. And it's an extreme form of a bowel hernia, of an enterocele. Then the uterine descent or the uterine prolapse. There is, here we see the hymen, and the uterus is still roughly hymen. The cervix of the uterus is hymen minus 2 centimeters. That would be a good way to describe this prolapse. Of course, we will determine the severity of the prolapse, the severity of the anatomical variation when she is pushing. Here we could see a cervical prolapse at the level of the introitus, that would be 0. This is a so-called Procidentia, or a complete prolapse, or a complete eversion. The cervix, the uterus, and in front the cystocele, and in the back the rectocele and an enterocele. So all pelvic organs are prolapsed, as we can see quite often in the elderly. We don't need to do a speculum examination because the prolapse is visible purely at inspection and even without Valsalva. For people who are not familiar with this type of presentation, as soon as they found out, they found it quite scary, but it's important to be familiar with this. Then we have prolapse grading systems. How to express the severity of a prolapse. Most importantly, the patient, the woman, will tell you, and you need to ask her. So do all the prolapse symptoms, do they contribute to hardly any limitations in your daily activities, or do they have a major impact on her quality of life? And important to think about the 4 different activities tracts, so the bladder, the vagina, and the rectum, and sexual activity, to find out how bad the prolapse actually is. For clinicians, we stage or classify the prolapse and we describe the degree of descent or the changes in the anatomy. The problem with grading, there are different systems, and they have been developed over time, and they have quite a considerable inter-observer variation. So at this stage we recommend to use the so-called POP-Q classification, which was agreed upon in 1996 by the International Continence Society. This diagram shows a few of the grading systems which were used in the past, and here on the right hand side we see the POP-Q classification. And the POP-Q classification uses the hymenal ring or the introitus as the reference point. The POP-Q classification has the advantage that it's less subjective and more reliably describes the severity of the anatomical variations. I do not want to go into detail here, but this is an overview of a diagram of all the 6 points in the vagina which are described in the POP-Q classification. So the anterior vaginal wall, 2 points, the posterior vaginal wall, 2 points, then the cervix is point C, the posterior fornix is point 2, and then we have a few other, so the genital hiatus and the perineal body. Here you can see the different stages, and for instance, if the most distal point of the prolapse is 1 centimeter above the hymen or at the hymen or 1 centimeter below the hymen, so in this range it's classified as POPQ stage 2. Here's an example of a rectocele, an isolated rectocele. There is a normal anterior vaginal wall. The uterus, the cervix, is not prolapsed, and we see a rectocele, hymen minus 1 centimeters. So that would be POPQ stage 1. Sorry, stage 2. Investigations are not required in daily practice. By the way, of note is that some urogynecologists might use special imaging, for instance an ultrasound scan, to demonstrate Levator Ani anine muscle avulsion, but that's not yet common practice. Conclusion of pelvic organ prolapse part 1. It's a common condition. The exact prevalence is not known, but it's common. It's probably 1/4 to half of all the women at beyond 50 years of age. The diagnosis of pelvic organ prolapse is a clinical diagnosis. Firstly, we need to be able to take a detailed history regarding the 3 tracts involved and combine that with thorough speculum and bimanual examination. Use the hymen as reference point. That is maybe the simplest way to describe the POPQ classification. So describe whether you see a cystocele, hymen plus 2 centimeters, and that makes clear to everybody what variation we're dealing with and the severity. And you assess the severity of the prolapse, the POPQ classification, when the woman is bearing down, coughing for instance. In principle, no investigations are required. Okay, this concludes part 1 of pelvic organ prolapse, and we can see now the sunset from my little room here 4 minutes later compared to the first picture. I hope you found this interesting and you're motivated to listen to part 2 of the pelvic organ prolapse DAROGA video. Thank you.